Bismillahirrahmanirrahim. This video is about clinical aspects of the neoplasia. These are the references for this video. The location of the tumor is important in determining the effect of the tumor. The tumor may infiltrate and invade the surrounding structures and that result in functional impairment as a result of necrosis. It also produces nidus for infection. Pituitary adenoma may compress adjacent tissue and result in destruction of the adjacent tissue due to pressure atrophy that results in hypopituitarism. Same is true for the primary or secondary endocrine neoplasia. Similarly, the brainstem glioma, which is benign in character, but due to its location in the brainstem that has got various important nuclei, may result in death despite the innocent nature of the glioma. The primary or secondary endocrine neoplasia may secrete excessive hormone or result in oversecretion associated syndrome. Such as one example is the insulinoma, in which there is excessive production of insulin that results in repeated hypoglycemic attack and other clinical signs and symptoms. There is another term that is paraneoplastic syndrome, which we will discuss in detail later, but it is the abnormal secretion of some of the hormones by tumor cells. Jaundice may result due to early involvement of the bile duct by pancreatic tumor, or it may result due to hepatocellular carcinoma, gallbladder carcinoma, or metastasis to the liver, that is fulminant. Then the gut tumors, both the benign or malignant tumors of the gut may produce obstruction or intussusception. The melena, that is the blood in stool, and hematuria, that is the blood in the urine, they may accompany the tumors of the gut or tumors of the kidney or urinary tract respectively, while any tumor may bleed locally and produce local signs and symptoms and systemic symptoms also. The tumor is also a site for secondary infection, especially if it is exposed. The cancer cachexia is a hypercatabolic state defined by a loss of muscle mass with or without loss of fat that cannot be explained by diminished food intake. The 50% of the cancer patient, they suffer from cancer cachexia, and it is more common in gastrointestinal tumors, pancreatic tumors, and advanced lung tumors. It is responsible for about 30% of the cancer deaths. This condition is a highly debilitating condition which is associated with extreme weight loss, fatigue, atrophy of the muscles, anemia, anorexia, and edema. The cancer cachexia is associated with loss of fat stores and loss of muscle. The inflammatory mediators such as TNF, interleukin 1, and interleukin 6 have been linked with the mechanism of muscle loss. Due to the inflammatory cytokines, there is activation of signaling pathways that lead to the ubiquitination of the target proteins, and there is subsequent proteasomal degradation of the major skeletal muscle structural protein such as the myosin heavy chain and there is resultant muscle loss. The atrophy of the diaphragm and respiratory muscle leads to death. The lipid mobilizing factor leads to the stimulation of the adipocytes to the lipolytic stimuli that will lead to the loss of fat store. This lipid mobilizing factor is isolated from sera and urine of advanced cancer patients. Fever is another feature that is associated with tumors. The Pyroxia of unknown origin is the condition that is present initially and it disappears after treatment. Fever reappears on a recurrence of the tumor, and most commonly the fever is associated with Hodgkin disease, renal cell carcinoma, and osteogenic sarcoma. And the fever is due to release of pyrogens from the tumor cell and interleukin 1 release from the stromal inflammatory cells. There is another entity that is termed as paraneoplastic syndrome. The paraneoplastic syndrome is exhibited by some cancer-bearing individuals who develop signs and symptoms that cannot readily be explained by the anatomic distribution of the tumor or by the elaboration of the hormones indigenous to the tissue from which the tumor arose. Earlier we have studied the local effect of a tumor. These paraneoplastic syndrome can be termed as a remote effect of the tumor. They occur in 10% of the person with cancer, and these are a group of rare disorders that are triggered by an abnormal immune response. Recognition of the paraneoplastic syndrome is important because the signs and symptoms produced by these syndromes may be the first manifestation of an occult neoplasm, and these may be mistaken for those produced by advanced metastatic disease, hence will lead to an inappropriate therapy. This paraneoplastic syndrome itself may be disabling, and treatment that alleviate those symptoms may have an important role in palliative effects. Certain tumor products that result in paraneoplastic syndrome provide a means of monitoring the recurrence of the cancer in patients who have had surgical resection or are undergoing chemotherapy or radiation therapy. One of the manifestations of paraneoplastic syndrome is endocrinopathy. The responsible cancers are not of endocrine origin, but there is ectopic hormone production by the secretory activity of these tumors. These are frequently encountered, and most common endocrinopathy is Cushing syndrome, and 50% of affected individuals have a small cell carcinoma of the lung. There is increased production of corticotropin or corticotropin-like peptide. The precursor of corticotropin is pro-opiomelanocortin, and the patient who have lung cancer with Cushing syndrome, they have increased level of both pro-opiomelanocortin and corticotropin. The hypercalcemia is the most common manifestation of the paraneoplastic syndrome. There are two mechanisms of cancer-associated hypercalcemia. One is the mechanism in which the bone tumor and metastatic or primary, they live in vicinity of the osteoclast, osteoblast, and stromal cell. The tumor cell release prostaglandin, cytokine, and parathyroid hormone-related peptide. that act on osteoblast and stromal cell and increase the expression of rank ligand. This increase of expression of rank ligand will result in increased osteoclastic activity that will result in bone resorption and increased serum calcium. The result of the bone resorption will liberate numerous matrix-bound growth factors such as transforming growth factor beta, insulin-like growth factor 1 and fibroblast growth factor that will function as nutrient for the tumor cells, and they are responsible for the tumor cell growth in that particular environment. When there is Wnt pathway activation, so there is a release of Wnt protein and there is osteoblastic activity, and tumor will result in a sclerotic mass, and these tumors are osteoblastic in nature. This mechanism is not the paraneoplastic syndrome mechanism. The next mechanism we are going to discuss is actually considered the paraneoplastic syndrome mechanism of the hypercalcemia, in which there is liberation of parathyroid hormone related peptide, and this parathyroid hormone related peptide is considered as calcemic humoral substance by extraosseous neoplasm. So this substance is releasing by the neoplasm that are not within the bone or related to the bone. This substance has got partial structural homology to the parathyroid hormone and binds to the parathyroid hormone receptor or parathyroid hormone related peptide receptors that are G protein coupled receptors. So this substance and hormone binding will result in increased bone resorption, increased calcium uptake and decreased phosphate transport that will lead to increased serum calcium. Keratinocyte normally they also secrete a small amount of parathyroid hormone related peptide, and the release of this parathyroid hormone related peptide from the keratinocyte it reflects the association of hypercalcemia that is seen in the squamous cell carcinoma. Other factors that are associated with the hypercalcemia are interleukin-1, transforming growth factor alpha, TNF and dihydroxyvitamin D. The tumors that are associated with hypercalcemia or hypercalcemic paraneoplastic syndrome are carcinoma of the breast, lung, especially the squamous cell carcinoma, kidney and ovary. Another manifestation is neuromyopathic paraneoplastic syndrome, which may take any form such as peripheral neuropathy, encephalitis, cortical cerebellar degeneration, a polymyopathy resembling polymyositis and myasthenia syndrome. Their cause is poorly understood, but it is considered that cancer-induced immunological attack of the normal tissue is responsible. This can be cell-mediated or antibody-mediated. In the cell-mediated type, the initiating event may be ectopic expression of antigens that normally are restricted to the neuromuscular system by the tumor cells. The immune system recognizes these antigens as foreign and it starts a response that leads to the tissue damage, and this takes the form of T-cell response. In some cases, antibodies that cross-react with the neuronal cell antigen are responsible. This is the proposed schema for the pathogenesis of neuromyopathic paraneoplastic syndrome. An onconeural antigen is expressed within the tumor cell. When the cell dies, the antigen is taken up by local dendritic cells or macrophages and it is presented to both cytotoxic and helper T cell by MHC class 1 and MHC class 2 respectively. CD8 positive T cell recognize the antigen on tumor cell and thereby contribute to the good tumor prognosis. And CD4 positive helper T cell, they migrate through the blood-brain barrier and home to the perivascular space where they help B cells to produce specific antibodies. They also prepare a pro-inflammatory microenvironment that include induction of MHC class 1 expression by neuron. This enables the cytotoxic T cell to attack the neuron. Another manifestation is acanthosis nigricans, which are the gray-black patches of thickened hyperkeratotic skin with velvety appearance, as we can see in this picture. These acanthosis nigricans are rare genetic diseases in juvenile or adults, but in 50% of the cases, particularly in people over the age of 40, the appearance of such lesion is associated with cancer, most commonly the carcinoma of the stomach. Acanthosis nigricans is sometimes accompanied by the abrupt development of multiple seborrheic keratosis, that is termed as lesser trilla sign, and these skin changes may appear before the cancer is discovered. Hypertrophic osteoarthropathy is another manifestation which has unknown etiology, and it affects 1 to 10% of the patient with lung carcinoma, and rarely it is associated with other form of the cancer. It is characterized by periosteal new bone formation that occurs primarily at the distal end of the long bone, metatarsal, metacarpal and proximal phalanx, as it is evident by this radiograph and marked by these arrows that there is new periosteal new bone formation in the shaft of the tibia and fibula, and it is accompanied by arthritis of the adjacent joint and clubbing of the digit. This radiographic picture of the osteoarthropathy is seldom seen in non-cancer patients, but clubbing is usually associated with liver diseases, diffuse lung diseases, congenital cyanotic heart diseases, ulcerative colitis, and other disorders. There are some vascular and hematologic manifestation also. One of them is migratory thrombophlebitis, that is also termed as Trousseau syndrome, and it is encountered in deep-seated cancers such as carcinoma of pancreas or lung. Disseminated intravascular cognition is associated with acute promyelocytic leukemia and prostatic adenocarcinoma, while bland, small, non-bacterial fibrinous vegetation sometimes also form on the cardiac valve leaflets, and these are more common on the left-sided valves, and these are associated with advanced mucin secreting adenocarcinomas. This table is showing the paraneoplastic syndromes, the endocrinopathies. One of the endocrinopathy is Cushing syndrome, that is due to excessive secretion of adrenocorticotropic hormone or adrenocorticotropic hormone like substance, and it is associated with a small cell carcinoma of the lung, pancreatic carcinoma and neural tumors. The syndrome of inappropriate antidiuretic hormone secretion
is due to excessive secretion of antidiuretic hormone or atrial natriuretic hormones, and it is seen in small cell carcinoma of the lung and intracranial neoplasms. Hypercalcemia is due to parathyroid hormone related protein transforming growth factor alpha, tumor necrotic factor, and interleukin 1, and it is seen in a small cell squamous cell carcinoma of the lung, breast carcinoma, renal carcinoma, and adult T cell leukemia and lymphoma. The hypoglycemia is due to insulin or insulin-like substances, which is seen in ovarian carcinoma, fibrosarcoma, and other mesenchymal tumors. The polycythemia is due to excessive release of erythropoietin, and it is present with renal carcinoma, cerebellar hemangioma, and hepatocellular carcinoma. Osteomalacia is due to fibroblast growth factor 23 excessive secretion, and it is seen in phosphaturic mesenchymal tumors. The nerve and muscle syndromes which are associated with these paraneoplastic syndrome are considered immunologic in origin, and myasthenia-like syndrome is seen in bronchogenic carcinoma and thymic neoplasia, while disorders of the central and peripheral nervous systems are seen in breast carcinoma. The dermatological disorders are acanthosis nigricans and dermatomyositis. The acanthosis nigricans is also due to immunologic etiology or secretion of epidermal growth factor, and it is seen in gastric carcinoma, lung carcinoma, and uterine carcinomas, while dermatomyositis is also considered immunologic in etiology and seen in bronchogenic carcinoma and breast carcinoma. The osseous, articular, and soft tissue changes, such as the hypertrophic osteoarthropathy and clubbing of the finger, has got unknown etiology, and this is seen in bronchogenic carcinoma and thymic neoplasms. There are various vascular and hematological changes also, such as venous thrombosis, that is the Trauzius phenomenon, and it is due to products of the tumor, and it is the mucin that activates the clotting. It is seen in pancreatic carcinoma, bronchogenic carcinoma, and other cancers. The DIC or disseminated intravascular coagulation is also due to tumor products that activate clotting, and it is seen in acute promyelocytic leukemia and prostatic carcinoma. The non-bacterial thrombotic endocarditis is due to hypercoagulable state, and it is seen in advanced cancers. Red cell aplasia has got unknown etiology, and it is seen in thymic neoplasms. The other paraneoplastic syndrome are nephrotic syndrome, that is due to tumor antigen and immune complex formation, and this nephrotic syndrome is seen in various cancers. The grading and staging of the tumor are done to determine the behavior of the tumor, the extent of the tumor, its prognosis, and to plan a treatment modality that is suitable for that particular type of the tumor. The grading of the tumor is based on the degree of differentiation of the tumor cell, and in some cancers the number of mitosis or architectural features. There are various grading systems. One is two-grade system. There are two categories and in these the tumors are graded as low grade and high grade. Some tumors are graded into well differentiated, moderately differentiated, and poorly differentiated, and these are the three-grade system. Some tumors are graded following a four-grade system. The grading is useful, but it is not giving the full picture of the tumor. It is not associated or correlating the histological appearance and biological behavior. So the tumors are described with the histological, the grade is described with the histological picture, such as the well differentiated mucin secreting adenocarcinoma of the stomach or poorly differentiated pancreatic adenocarcinoma. So in this name, almost everything is described: the morphology of the tumor, the location of the tumor, and what is the characteristic of the tumor, and its grade also. What is the grade of the tumor? Following is described the grading schemes, various grading schemes for the soft tissue tumors for the better understanding.
Various grading systems have been used by the pathologists for the grading of soft tissue tumors. So the number may be different for various grading system. There are various grading system. One is the two grade system, and this two grade system divides the tumor into grade 1 and grade 2, and these are the low grade and high grade, while the three grade system divides the tumors into grade 1 to 3 and label these as low grade, intermediate grade and high grade, while the 4 grade system grades the tumor in grade 1 through 4. Finally, there is another grading system, that is FNCL-CC grade system, which is basically highlighted dependent on tumor differentiation or degree of cytologic age, mitotic count and presence or absence of tumor necrosis. The FNCLCC system of grading, or French Federation of Cancer Center Sarcoma Group grading system, is the system which considers tumor differentiation, mitotic count and tumor necrosis as the grading criteria. The score is given 1 when sarcoma closely resemble to normal adult mesenchymal tissue, for example in well differentiated liposarcoma and well differentiated fibrosarcoma, and score is given 2 when sarcoma for which the histological typing is certain, such as biphasic synovial sarcoma, alveolar soft part sarcoma and myxoid liposarcoma. A score is given 3 for the sarcoma of the doubtful tumor type, such as embryonal sarcoma and undifferentiated sarcomas. Mitosis is counted under high power for 10 successive failed, and score is established as 0 to 9 mitosis per 10 field is given 1. When these mitoses are 10 to 19, score is given 2, and when these mitoses are more than 20, the score is given 3. When there is no necrosis in any examined slide, this tumor necrosis is given 0 score, and if less than 50% of the necrosis is present in the examined tumor surface, it is scored as 1, and if it is present in more than 50% of the examined tumor surface, it is graded as scored as 2. So when the tumor attains a score from 2 to 3, it is given grade 1, and when it is scored 4 to 5, it is considered as grade 2, and when the score is 6 to 8, it is considered as grade 3. So we have got two extremes. One is closely resembling to the normal tissue, and another has lost its normal appearance. The one close to the normal tissue appearance is well differentiated, and one that has lost all its normal characteristic is poorly differentiated or anaplastic, while the one in between these two, loosely termed as moderately differentiated, which has got some resemblance to the normal tissue, but still you can judge, or you can say that the tissue of origin is that particular tissue. Okay, so there is well differentiated, moderately differentiated and poorly differentiated entity of these tumors.
The staging of the tumor describes many anatomic features of a tumor, such as size of the primary lesion spread to the regional lymph node, and they also describe the presence or absence of blood-borne metastasis. The current staging system for the tumors is American Joint Committee on Cancer Staging, that is also termed as AJCC staging system or TNM system for staging, where T stands for primary tumor, N for regional lymph node involvement, and M for metastasis. The general principle followed for the staging of these neoplasm is the primary lesion is denoted T1 to T4 based on increasing size, while T0 is used for in situ lesion. For nodes, N is used and N0 would mean no nodal involvement, while N1 to N3 would denote involvement of an increasing number and range of nodes. M0 signifies no distant metastasis, whereas M1 or M2 sometimes indicate the presence of metastasis and some judgment as to their number. It is increasingly now evident that there are some molecular features of these solid tumors that provide important prognostic information. That molecular signature or molecular information of a tumor is independent of the anatomic characteristic of the tumor. This table is describing the AJCC staging system for breast tumor. The breast tumors are staged from 0 to 4, and all three parameters, the tumor, node and metastasis, are considered in this staging system. The stage 0 is for ductal carcinoma in situ or lobular carcinoma in situ, which have got no metastasis to the lymph node or distant metastasis, and the 10-year survival for these tumors is 92%. The stage 1 is tumors are designated when they are invasive and less than 2 cm in size, 2 cm or less than 2 cm in size. There is no metastasis distantly, but to the local lymph node there is micrometastasis present, and the 10-year survival for these tumors is 87%. The stage 2 can be invasive carcinomas that are more than 2 cm with 1 to 3 positive lymph nodes and the distant metastasis is absent. Or these stage 2 tumor can be invasive carcinomas that are more than 5 cm but less than 5 cm or equal to the 5 cm with 0 to 3 positive lymph node and the distant metastasis is absent. The survival is 65%. Stage 3 tumors of the breast can be invasive carcinoma more than 5 cm, negative or positive for lymph nodes, distant metastasis is absent, or any size of the invasive carcinoma with more than 4 positive lymph node, still metastasis is not there, or invasive carcinoma with skin or chest wall involvement or inflammatory carcinoma with negative or positive lymph node but there is no distant metastasis, still the survival is 40%. The stage 4 is not related with the size of the tumor mostly, it is associated with presence of distant metastasis. It is not related with the size, neither related with the presence or absence of metastasis with the regional lymph node. There is presence of distant metastasis and the survival rate is 5% only. The 10-year survival is only 5%. In the following section, we will see the AJC system of the soft tissue tumor for better understanding of this staging system, which has also incorporated the histological grade of the tumor into consideration.
Comprised of tumor, node and metastasis with histological grading. All these four elements are considered for the TNM staging, and tumor is staged as T0 if there is no evidence of primary tumor, and T1 when it is less than 5 cm and T2 when it is more than 5 cm. When there is no regional metastasis, it is termed as T0, and if there is regional metastasis, it is termed designated as N1. If there is no distinct metastasis, it is termed as M0, while designated M1 when it is present with distant metastasis. Histopathological grading is divided into 4, G1 to G4, well differentiated, moderately differentiated, poorly and undifferentiated soft tissue tumor, and based on these criteria they are staged into stage 1, stage 1A, stage 1B, stage 2A, 2B, 3A, 3B, 4A and 4B.
Increasing attempts are now being made to segregate the tumor on the basis of their molecular signature or the changes which they have got. For example, the breast tumors have now been divided into 3 groups, such as ER positive, HER2 negative, and HER2 positive and ER may be positive or negative, or ER negative, HER2 negative, or triple negative tumors. And each of these type is associated with a specific genetic mutation and show characteristics which are in detail in this table.